Okay, so sorry, I think there were some changes to the program, and the first talk will actually be by Professor Clarisse Eveno. She's going to give us a talk on the advances in the surgical management of peritoneal disease. I think we heard from her this morning, but Prof. Eveno is from the Department of Surgical Oncology in Lille, France, and has been engaged in the treatment of peritoneal disease for the last 15 years. She's very well published and has a rich experience in the resection of peritoneal surface malignancies, intraperitoneal chemotherapy with PIPEC and HIPEC for locally advanced and digestive ovarian cancer. So without further ado, we'd like to invite Prof. Eveno to the stage. Thank you.
So good afternoon. I would like to thank again Jimmy for the organization and to give me the opportunity to speak with you about peritoneal disease. So what is the goal of peritoneal disease treatment is to achieve a complete cytoreductive surgery with low morbidity and in accordance with oncologic strategy. So what about the disease extension? We have some old knowledge, but also new insights that I would like to discuss. Bless you. What is the principle of surgery? So we need to have an homogeneous evaluation of the PCI, and it's the Sugar-Baker score that we will use on 39 points. And the principle of surgery is to resect all the macroscopic disease with cytoreductive surgery, and sometimes to treat the microscopic disease with IPEC. So we know that it's very difficult, but also we need to do a perfect cytoreductive surgery with a CC0 classification with no residual disease at the end of the surgery. So in France, like 10 years ago, we discussed our practice, and you can see here the survival curve of all the etiology of peritoneal disease, and the gastric cancer is very low. So what about colorectal disease? You can see here on our series of 400 patients that the survival curve are very related to PCI, and that we need to understand how far we will need to go. Even if the disease is resectable, it might be not good to resect patients with more than 20 or 24 of PCI. In this study from Gustave Roussy, you can see that after 17 of PCI, we don't have any gain of survival if we remove all the disease if the tumor burden is more than 17. So we have to think about the tumor burden. In gastric cancer, we compared two strategies with cytoreductive surgery alone and cytoreductive surgery with IPEC. It was 25 years of experience, French practice, and we compare almost 100 cytoreductive surgery and 180 cytoreductive surgery and IPEC. The rate of CC0 reduction was 79, and the mortality was quite high with 8.4%. The morbidity, the major morbidity was half of the patient. And so when we use a propensity analysis on all the prognosis factor, when we do this propensity score, we had some trouble to add some comparable PCI, and the PCI were 6 on the IPEC group and 2 for the median PCI in the cytoreductive surgery alone. And you can see here that with IPEC, we gain 7 months of median overall survival. So what about patients with gastric cancer with poorly cohesive cells? You can see here that this is the same cohort, and you see that there is a strong effect of poorly cohesive cancer cells with a mean survival, median survival of 14 comparing to 20 when we don't have these cells. So we have to adapt the PCIs with the disease. And the cutoff of PCI that we defined was 7 for patients with poorly cohesive cells and 12 for non-poorly cohesive cells. And in this study, the benefits of IPEC was preserved in patients with PCC or without PCC. So what about patients that we can't get to a curative treatment? This is a PIPAC for pressurized intraperitoneal aerosol chemotherapy. This is a new delivery way to get intraperitoneal chemotherapy. For now, it's mostly for palliative treatment in alternance of IV chemo. And it's safe, it's preserving quality of life, and it's currently being evaluated for improved survival. In this cohort of patients, 42 patients from the French group of Olivier Gléhen, 163 PIPAC, and we get 90 months of overall survival. 14% of the patients became resectable. So in this PIPAC cohort study that has been presented last year in PSOGI Congress, we have almost 600 treated patients with PIPAC. And this is a slide from Dr. Aliami. And with a median age of 56, the sex was well balanced. And you can see that you have a majority of ASA1 and ASA2 score. We have a lot of patients with SRC cells, 62%, and most of the PIPAC was given with interval IV chemo, and the postoperative death was below 2%. So this is the overall survival that we can get with this kind of treatment, 15 months for the median overall survival. But when you achieve to give more than 3 PIPAC, the overall survival are up to 20 months. So this is why we start this randomized phase 2 trial so we do in France, and I'm the PI, so to compare in palliative settings in gastric cancer, the IV chemotherapy group, so only IV chemotherapy, comparing to IV and PIPAC with cisplatin and doxorubicin. So for now, the trial was stopped for a safety issue, and we are going to present the results in ISSPP. We are still working on it. So what about peritoneal specificity? In colorectal cancer, you know, I presented you earlier this study. So the median survival for peritoneal disease is 60 months when it's treated with IV chemo. And comparing to other sites of peritoneal disease, of metastatic disease, peritoneal disease were more likely to be women to have colon cancer, to have a low performance status, and to be BRAF mutated with 18% of BRAF mutated in isolated peritoneal disease. So when we look at the genomic alteration in colorectal metastases, you can see that BRAF mutation is not so rare. And when we try to operate this patient, you can see that comparing to other type of molecular mutation, the survival is very bad, with a median survival, overall survival of 21 months comparing to 52 months for patients with wild type mutation, with no mutation. So what about MSI metastatic colorectal cancer? It's about 5% of patients from Lynch syndrome or sporadic origin. And it's going to make more frequent peritoneal disease and if not dissemination. But the prognosis was transformed by immunotherapy. You can see here the comparison of treatment of metastatic colorectal patient with chemotherapy and pembrolizumab. So this is a long-term result that has just been published. And so should we operate this patient after a good response? Well, when there is a complete response, I think we should make a long-term immunotherapy treatment, about 2 years. But what can we do after a partial or a stable disease? Should we operate this patient? This is a question. And we have made a study on our French group from 10 years of practice. We had 45 patients with peritoneal colorectal cancer treated with immunotherapy. 76% of monotherapy and 24% with a combination of immunotherapy. So the response was complete in 24%. More than half patients had stable or partial response, and we made 8 surgeries, and 7 patients had complete pathological response. You can see here a 27-year-old man with a Lynch syndrome, and after 8 cycles of pembrolizumab, he had a cytoreductive surgery with IPEC, with mitomycin-based IPEC, and all the disease was only mucin with complete pathological response. So what about prophylactic IP treatment? Because timing is everything, and we are still trying to figure out what to do to help people. So the recurrence of disease with peritoneal metastasis is induced by locally advanced gastric cancer, but also with the surgical trauma. You can see here a study on 102 patients with 2/3 of them had initial negative cytology, and after the gastrectomy, the cytology became positive with proliferative cells, and you can see here when the cells are put in the peritoneum of the mice that it's going to make some peritoneal recurrence. So Jimmy, this is your idea to make some peritoneal washing to treat the cells that could go to the peritoneum and make metastasis. And the patient were selected to have clinical T4 or clinical T3 or T4 gastric cancer, and after gastrectomy, they were randomized to have classical gastrectomy or with peritoneal washing. More than 400 patients in each group, and there is no difference in overall survival. So this peritoneal washing, this kind of peritoneal washing won't improve the survival. So what can we do? Should we add some chemotherapy after the gastrectomy? This is the idea of gastriship. This is the same idea. In locally advanced cancer of gastric cancer, after chemotherapy, if there is no peritoneal disease that are showed in the explorative surgery, then patients were randomized into gastrectomy and gastrectomy with IPEC. So this study is close to inclusion, and we are waiting for the results. But in this study that I showed you earlier, we can see that when there is some microscopic disease with peritoneal cytology, with positive peritoneal cytology or ovarian metastasis or microscopic peritoneal invasion, you can see that when you add the IPEC to the cytoreductive surgery, you gain 10 months of survival. So we may think that there is an advantage of adding IPEC in microscopic disease. So what about colorectal metastasis? There is 2 negative studies with oxaliplatin-based IPEC, with the quick ship. The first one is Profellowship, it's a French study. The patient had minimal resected peritoneal metastasis or ovarian cancer or perforated colon cancer, and after 6 months of FOLFOX, If there is no peritoneal metastasis that has been shown in the CT scan, patients were randomized between surveillance and systemic laparotomy with oxaliplatin-based IPEC. So the problem is that this is not prophylactic because we already have some peritoneal disease. And also that the use of oxaliplatin for IPEC is done in patients with progressive disease with under IV oxaliplatin. And you can see that there is no difference in the two groups, so there is no benefit to add this quick ship at the beginning of the story in this kind of patient. The other negative study is COLOPEC. So it's different patients with CT for N0 or N2 patient or perforated colorectal cancer. And they were randomized into colectomy, standard colectomy or colectomy with oxaliplatin and IPEC, either synchronously or between 5 to 8 weeks after the colectomy. And they also receive adjuvant FOLFOX. So the problem is that we had already some peritoneal disease in 12% after 5 to 8 weeks. So it's difficult to interpret, and there is no difference between the two groups. So this study was just presented in ESMO last week. So it's a Spanish study from Alvaro Arjona Sanchez, and it's exploring the adjunction of IPEC with mitomycin after a colic surgery for T4 patients. So it was a randomization of clinical T4 N0 or N2 patients. So 184 patients were randomized for surgery or surgery and IPEC with mitomycin C with high dosage and 60 minutes of IPEC. They are all adjuvant chemotherapy. And you can see here that the pathological T4 stage was comparable between the two groups, and all the characteristics of the patient are comparable. And you can see that the local regional control survival was different. We had a gain of survival in the IPEC group, and it's even more clearer in the PT4 subgroup. We had no difference in the disease-free survival or overall survival. And the morbidity was comparable, 25 and 18% of major morbidity, and the mortality at 30 days very low, 1 and 2%. So the conclusion of the study was to have some kind of new perspective of adding IPEC in this kind of population. And this is a real study on prophylactic IPEC because it's clinical T4 patients and well selected. So this is why we switch also from mitomycin IPEC. So what about the surgery? How to achieve the surgery goal? So here you have the peritonectomy procedures that has been published at the beginning of the 90s by Sugar Baker, and this is the same procedures that we perform now, we have to control our morbidity because, as you can imagine, you have to remove a lot of different organs and occasion some mortality. So when you see all the retrospective study, this paper was published in early 20s. So you can see that mortality ranged from 0 to 17%, almost 3% of mortality, and with a mean major morbidity of 30. But when you compare the IPEC procedure to other major surgery, you can see here that the mortality rate is comparable between the IPEC procedure and some complex liver surgery or Whipple procedure. So we made an an analysis of our 10 years period in French of mortality, and on 7,000 procedures, including all IPEC nationwide, we had a control mortality rate at 90 days of 2.6% and major morbidity of 45%. And for expert centers, with more than 45 procedures per year, there is a significant decrease in 90-day postoperative mortality, and the failure to rescue was divided by 2 to 6, from 6 to 3%. So should we add IPEC? This is a very hard topic for some etiologies. In ovarian cancer, we have some strong data for interval surgery. You can see here the publication of patients with stage 3 epithelial ovarian cancer that had chemotherapy, neoadjuvant chemotherapy, and when they became resectable with a residual tumor measuring of less than 1 millimeter, the patient was randomized between cytoreductive surgery alone and cytoreductive surgery with IPEC. And this is a cisplatin IPEC. And you can see that there's a very low grade 3 and 4 morbidity, 25 and 27% of the population, and the mortality rate was below 1%. And when you add IPEC after your cytoreductive surgery, you gain 4 months of recurrence-free survival and 1 year of overall survival in this population. So what about pseudomyxoma peritoneae? I don't think that you see clearly the numbers, but you can understand that you have more than 2,000 patients that were treated with cytoreductive surgery alone or with IPEC. And after a very strong matching, we had 300 patients in each group. And you can see here that there is a benefit in adding IPEC in this population. So in gastric cancer, I already show you that we gain more than 6 months for adding the mitomycin C IPEC. And of course, the hot topics is colorectal cancer, because we had a randomized study named PRODIGE-7 that has been communicated in 2018 in ASCO. And I think you may be familiar with this study because it has been very famous. Because the French people, we just try to understand if IPEC is doing good in colorectal peritoneal disease. So after the surgery, we should be complete with the minimal resection rate was 1 millimeter. So in the OR, we randomize a patient between IPEC, it's oxaliplatin IPEC, or no IPEC. And patient had some neoadjuvant chemotherapy or perioperative chemotherapy. So with this type of IPEC, called the quick ship, because it's short, it's 30 minutes, there is no gain of survival with the IPEC. But this study is positive because we have a 40 months median of survival in this group. When you operate the patient completely in an expert center, you have a 40 months median of survival. So this study was very much debated, and in France, we had some kind of expert opinion, and we are called to change the drug of the IPEC in favor of mitomycin C. And this is what we are going to see also in the PSOGI Delphi process, that we are switching for mitomycin C. So we analyze the French practice after the communication of the PRODIGE-7 results in 2018, and we see that in France, we had a small decrease in university hospital, a small decrease of IPEC, but in cancer centers, the practice was different, and we had a real decrease after the communication of PRODIGE-7. So we made a small study on patients with colorectal disease, with peritoneal colorectal disease, operating in France in 5 expert centers with mitomycin C IPEC between June 2018 and June 2021, so after the Prodigy 7 study. And in high-volume center, we analyze the perioperative data, and we see that when you use mitomycin C based IPEC with 25 milligrams per square and a fractionated protocol with a long time of IPEC of 19 minutes, we made a matching propensity score with based on age as a score, the number of resected organ and the length of surgery. And I'm sorry, it's in French, but you can see that when you use the protocol that is just here, you have 14% of major morbidity. So when you're operated in expert center with this kind of surgery and mitomycin C IPEC, you have a very low morbidity rate after this kind of surgery. Our overall survival at 3 years was 72%. And so at the end of my talk, the take-home message was will be to select some good candidates for surgery with limited PCI and especially with sinoatrial cells cancers in accordance with molecular mutation, to address patients in expert centers to reduce surgical morbidity, and that there is a place for mitomycin C IPEC in prophylactic and curative settings of colorectal disease, but it's still under debate. Thank you for your kind attention.
Perhaps you can take some questions from the floor. Prof. So?
Yeah, thank you. Thanks, Clarisse, for the wonderful talk. I think for the management and the outcome for peritoneal metastasis, the size of primary is a key factors, whether it's a stomach, whether it's colon, whether it's ovarian. And I think in France, they are pretty more aggressive for gastric cancer, peritoneal metastasis compared to the rest of the world. So can you share with us some of your experience of using CRS HiPET for patients with peritoneal metastasis from a gastric cancer?
So I think you're right, but I think it's a very low number of patients, because you have to make a laparoscopy at the beginning of the story to be sure that the PCI is low. And after neoadjuvant chemotherapy, you repeat the laparoscopy to be sure that the PCI is low. And 7 of PCI is very low. So we have few candidates. So if you select very carefully this type of patient, you may add some survival for them, with the gastrectomy and very limited cytoreductive surgery. Maybe there's a place to do this type of surgery, but it's small amounts of patients.
Thank you.
Perhaps I can follow up with that question. We have a lot of patients who undergo PIPEC as well as bidirectional chemotherapy for gastric cancer. And when we go back in and do the diagnostic laparoscopy, it's always a challenge to see, is it really disease or is it, treated disease, or has it all responded? What would be your perhaps some tips or take-home messages on perhaps doing the diagnostic laparoscopy for this group of patients?
Yeah, so when you repeat PIPEC, you have some patients that had some strong and big nodules, and then they became very flat because they respond to chemotherapy. And this is why this is the interest of PIPEC, because you have a look at the disease, but you also have a microscopic evaluation because you have to perform biopsy, and you should do some multiple biopsy. Not 1, not 2, but 3 or 4, and to do the score of regression after chemotherapy. And that way you can see that if the PCI that you see is only macroscopic or it's also microscopic. Because sometimes you have a complete response.
Thank you. There's one question that I had. In colorectal metastasis, do you see a role of combining, let's say, liver resection with with peritonectomy and HIPEC in case there's liver metastasis?
I don't. What
If there's liver metastasis and there is peritoneal disease, is there a role?
Yeah, there's a
for
role because you have to be aware of the tumor burden. So if you have a high PCI with no liver metastasis, you can go up to 20 or something, 17, 20 of PCI. But as soon as you have some liver metastasis, you have to get a tumor burden that is comparable. So you have to get the PCI very low. So when you have a lymph node or liver metastasis, you will choose to get a very small PCI like 12 or below. So yeah, with strong laparoscopic evaluation before to perform the IPEC.
Thank you.
Could I also just ask about your results for the immunotherapy for the colorectal cancer? I thought that was quite interesting. And I think in that group that had partial and stable disease, you went on to perform surgery for 8 of them. What happened to the rest of them, perhaps? And I think 7 out of 8 of them, you said, had actually pathological complete response. Perhaps then, in this group of patients, did we not even need to do the CRS and HIPEC then?
Of course, yeah. I show you some picture of the CT scan and the operative room view, and we had some very strong nodules, and it was a complete response, but we still have mucus. So I don't know if we have to operate this patient or just make a strong surveillance to see what will it be. But for now, we don't really know. It's easier when you have a complete response, because it's easier.
Okay, and perhaps just one last question. I think, as we talk more about minimally invasive surgery nowadays, CRS and HIPEC is a maximally invasive surgery, but doing it laparoscopically is becoming a hot topic nowadays. Do you perform any, and what's perhaps your take-home message on laparoscopic CRS and HIPEC?
Yeah, it's a hot topic. So I think what I present to you, it's for aggressive cancer. And the laparoscopic surgery should be, I think, reserved to patients with low-grade metastasis, like low-grade disease, like mesothelioma, multicystic mesothelioma, or a patient with low-grade pseudomyxoma with very small amount of tumor. But as soon as you have an aggressive cancer, we know that when you perform a laparoscopic evaluation, and after that you do the open procedure, you will gain 3 or 4 points of PCI. So for now, we don't have any kind of data on survival for treating this patient with laparoscopic cytoreductive surgery for aggressive cancer. We only have a morbidity study, so it's difficult to do it.
I think we can move to the next.
Okay.
Yeah. Thank you very much.
Thank you.
I think it was a great talk. Thank you. So